Good afternoon, everybody. Welcome to Burn Care the PMB Way. Today we're going to be talking about burn assessment, and that includes understanding both the total body surface area as well as the depth in the acute burn. I'll start with total body surface area because that's the easier one to get your head around. And there's a number of different ways you can assess the burn. The easy and generally well-known one is the rule of nines, seen on the top left, where the head and neck in an adult is 9, but in a child it's 18. The trunk, both anterior is 18 and then posterior is 18, each arm being 9, each leg being 18, and that would be 9 in the front, 9 in the back. Now with a child, to accommodate for the larger surface area of the head and the scalp and the head accounting for 18%, that means we need to take 4% away from each of the legs. So each leg in total will be 14%, so 7 in the front, 7 in the back, and that's generally the easier one to remember. However, it can overestimate the burn, and we prefer the Lunt and Browder chart, as seen there on your right-hand side. With the age of the patient, each of the components A, B, and C change in size. So it's a more accurate way of measuring a burn. Total body surface area, some people believe that this should only be used for children and you should stick to the rule of nines for adults. I think you can use the Lunt and Browder chart for both. The other easy one to remember is the hand rule, and that the open hand will represent 1% of the total body surface area of the patient. Now, make sure that you're looking at the size of the patient's hand and not your own hand to use that. It's particularly useful if it's a very patchy burn. It can also be used in very large surface area burns where you can measure the non-burnt areas using the hand rule and then subtract the total from 100. A key point in being able to accurately assess the burn size is to actually use it on a chart and color in the distribution of the burn on the piece of paper to work out bit by bit and add it all up in the end, because eyeballing it doesn't generally tend to work that well. You actually need to draw the burn onto the chart and measure it accordingly. Now moving on to burn depth, I like to start with the anatomy of the skin, and you get glabrous skin, which is only included on your palms and soles, and the rest of the skin on your body is considered hairy skin. And the components are the epidermis and the dermis, where the epidermis is the component that has the basal epithelial layer, that's the active layer that rapidly divides to renew the epidermis or heal a superficial partial burn by epithelialization. And it invaginates down around the skin appendages like the sweat glands and the hair follicles. The dermis is below that, and that's the component of your skin that has the fibrin and the elastin. So it offers your skin the qualities of strength and elasticity, which is important later when we're talking about scars, because the less dermis you have, the poorer your scar, because of exactly the components that are lacking in that layer, the elastic properties and the tensile strength. Now, I really would like to highlight this layer of basal epithelial cells that you see here in pink, invaginating down around the hair follicle or the sweat gland. And you see it coming down into the depth of the dermis at varying levels. When you look at the surface of the skin from the top, just take note of those pink circles and that are highlighted by the arrow. Those are your very richly populated or densely populated islands of basal epithelial cells around those skin appendages. And here, when you see the healing of a superficial partial burn, and it's easy to see on a pigmented patient. Those little stipples, those are the basal epithelial cells that have started to regenerate. As time goes by, those will coalesce to cover the entire burn wound, and your melanocytes will follow. And in the end, the pigment will come back. In terms of depth, the volume of cells left after the injury are really key to understanding healing. So if you look there at an epidermal burn, the damage is just done to the epidermis, and there's a huge volume of basal epithelial cells left behind, and that is basically a sunburn, and that's going to heal quite well. In a superficial partial thickness burn, you see there is damage of some of the dermis, but there's still a large proportion of basal epithelial cells that remain behind. So healing is good, and those wounds will heal. Whereas a deep partial thickness burn, there may be some of those islands deep in the dermis, but they are few and far between, and healing is highly unlikely. And the real key here is 21 days to heal. And we're going to talk about this a little bit more. But the healing is really dependent on how many basal cell islands are left intact. And the defining point in time is 21 days. All superficial partial thickness wounds will heal by 21 days. If the actual damage done is to the depth of deep partial or full thickness burn, that means by 21 days there has not been healing, or there's been inadequate or insufficient healing because of those basal epithelial cells left behind. And you should be looking at an unhealed wound. And a burn that hasn't healed by 21 days is deep partial or full thickness and requires skin grafting. And this is the classic description or classification of depth. And I've put the terms degrees in brackets next to them, and we really have moved away from using the word degree to describe it. And you see here why. And the problem is really the second degree burn that is dermal or partial. Now, dermal and partial are interchangeable words. For example, you can have a superficial partial burn or a superficial dermal burn, and then on the other end of the spectrum, a deep dermal or deep partial burn. Now, as we've discussed in the previous slide, a superficial partial burn will heal. However, a deep dermal burn needs skin grafting. Now, it's not very practical to classify both of those depths of burn under second degree because the management is different, being surgery is not required for healing versus surgery is. And then obviously a full thickness burn, otherwise known as a third degree, you've got no dermis left, all the dermis has been destroyed, all your basal epithelial cell islands have been destroyed, and certainly surgery is required there. So we don't use the terminology degrees anymore for this specific purpose. And here is a visual representation. That partial burn is nice and pink and shiny. If you've seen a number of burns, you would think that this probably has the potential to heal, versus the deep dermal or full thickness burn that looks leathery. It's got a more charred appearance, certainly on the right. And even on the left is more red, and that's the deep dermal component. And this would be the classic table seen in a textbook to describe the characteristics of each of those burns. And you see the problem comes in the mid-partial or the indeterminate burn, because it can look like either a superficial partial or a deep partial burn. I'd also like to draw your attention to the classification of healing, 7 to 14 days, but can be up to 21 days. The deep partial burn is more than 21 days, and the full thickness does not heal. Blisters may be present in any of those burns, and then blanching is probably the most useful clinical tool to determine the difference between a superficial partial burn and a deep partial or a full thickness burn, where you've got sluggish, minimal, or no capillary blanching. And here's a classic superficial partial burn, pink, shiny, and moist, typically caused by a hot water splash. This is the picture you've seen earlier. That's a healing, and actually a just about completely epithelialized superficial partial burn, as opposed to a full thickness burn here that looks more pale. If you touch it, it'll feel leathery. There will be no capillary refill or blanching. And then that difficult one, that indeterminate or mid-dermal burn, where healing is uncertain. They can often be quite mixed or heterogeneous, and often we need to take a more conservative or expectant approach, and we wait and see. What will heal at 21 days, and those that don't will require skin grafting. And here you see different versions of an indeterminate burn. The left one looks really quite mottled as opposed to the right one, which looks quite red. And here I would certainly want to do blanching to get an idea of capillary refill to determine that potential for healing. Here you see what we would have labeled as an indeterminate burn at day 21. And there you see the patches that have not quite epithelialized yet, and those then are by definition a deep dermal burn. So to summarize, partial burn will heal. Those mid-dermal or indeterminate burns, we're not sure, so management is expected, versus deep dermal and full thickness, which require excision and grafting. The importance of depth is not only significant for understanding the path of management, but it talks to a couple of other issues. For example, the partial wounds will usually have minimal scarring. Modern wound technology means that we can get away with sometimes a single dressing until the point of healing, and the patients really generally have a good outcome. Whereas the deep burns, they require surgery. If they are circumferential and deep, they require escharotomy. The path of care will require many dressing changes. They've got a higher risk of sepsis. They will have a degree of scarring and contracture. The outcome and prognosis is definitely not as good as a partial burn, specifically in the larger surface area burns. Counseling of the patient and the family would be quite different. And then you've got other problems like long-term pain and itch, and the need for reconstruction potentially. So really just to end off by highlighting this layer of basal epithelial cells, which I've really focused on this presentation for you to understand how they appear around the skin appendages into the layer of the dermis, and really how many of those are left are going to determine healing. And then lastly, to talk about the goals in burn depth. The goal in a partial burn is to prevent infection and prevent depth conversion to a deeper burn. We would like to minimally disturb that wound, and a single dressing that can be removed when healed would be ideal. For the mid-dermal burn, we want to allow healing of the partial area. We want to prevent infection and wait for the demarcation of the deep dermal areas that would require skin grafting. And then full thickness, our goal is to prevent infection prior to surgery with an aim for early surgery and closure with skin grafts or skin substitutes such as allograft. But we'll be going into a lot more detail on the different components of management and surgery in future tutorials. Thank you.